Okay, so today we're going deep on soft tissue coverage for fingers and hands, bread and butter for the plastic surgery boards.
Absolutely essential.
And luckily, we've got this awesome review article that covers secondary healing grafts, local flaps, distant flaps, all that jazz.
Sounds good. Let's break it down.
All right, let's start with the simplest option, secondary healing. When does this even work?
Well, it's going to be a small wound on a fingertip, and we're talking like excellent cosmetic and functional outcome expected.
Right, so not just small, but also in a good spot.
Exactly. Now, what you don't want is exposed bone wounds bigger than a centimeter squared, and those more proximal wounds.
Because that nasty hook nail deformity.
Yeah, exactly.
Yeah.
With those bigger or more proximal wounds, you get way more contraction, and that can pull the nail bed into a weird shape.
Got it. So when secondary healing's out, skin grafts are up next? When are those our go-to?
So for grafts, you need a nice vascular bed, like on the volar or dorsal side of the hand.
Makes sense. Need something for that graft to take this.
Yep, and they're great for those surgical defects, too, like donor sites from local flaps.
Okay, what about when you wouldn't use a graft?
Definitely not on exposed bone or tendon without that periosteum or peritoneum. You need that vascularity.
Right, or cross-flexion creases. You don't want to create a contracture there.
Exactly. Now let's talk graft types. Split thickness. What do we need to know?
Yeah, break it down.
So split thickness, that's your epidermis and part of the dermis. We usually take it from somewhere thick and tough, like the thigh.
Low sensitivity areas, right?
Yeah, you got it. And remember, they contract more secondarily because there are fewer of those elastic fibers from the dermis.
Makes sense. So for hand surgery, sheet grafts are best.
Absolutely. Better cosmesis all the way.
Now, full thickness grafts.
Yeah.
What's the deal with those?
Right, so full thickness, that's the whole shebang, epidermis and all of the dermis, usually from places with extra skin.
Like the groin or that supraclavicular area?
Yep, and because they've got all that dermis, they have more primary contraction but less secondary.
Interesting. So less contraction overall than the split thickness.
Right, and then we got those glabrous skin grafts.
Those are for balms, right?
Exactly, you'd take it from the hypothenar area or the sole of the foot.
And that thick stratum corneum sloughs off eventually.
Yeah, it'll regenerate though, don't worry.
All right, let's get into local flaps for fingers. Revision amputation. When do we do that?
So this is for those acute fingertip amputations or when a replant just doesn't work out.
So basically when you can't save the fingertip.
Yeah, sadly. But the good news is it's a pretty straightforward procedure. Shorten the bone, clean it up close, the soft tissue.
Seems simple enough. What are the downsides?
Well, you can get FDP adhesions, and that can lead to the quadriga effect.
Which is,
Right. When you bend one finger, it limits the others.
then there's the hypersensitivity issue.
Yeah, a lot of patients end up with that.
Moving on to the Adesoy-Kleinert flap. Sounds fancy.
It's a classic. This one's a volar VY advancement flap,
Yeah.
great for preserving sensation and that nice pulp volume.
I like it. And it's good for those dorsal oblique amputations, right?
Exactly. Especially when you have enough volar tissue to work with.
So how do you raise this flap?
Just above the periosteum. And here's a pro tip. Use a glove with a finger hole as a tourniquet. Keeps the field nice and bloodless.
Clever. Okay, what about Cutler flaps? Those are VY too, right?
Yep, bilateral and lateral base, though. Key point is they save the neurovascular bundles.
Smart. So you just mobilize them to cover that midline defect?
Right. And they're best for small defects like 1 to 1.5 centimeters.
Nice. And then there's the homodigital island flap.
Yeah.
When's that one appropriate?
So think fingertip wound that needs a flap but isn't super contaminated.
Okay, and the contraindication?
If either digital artery is injured, you're out of luck.
Because you need both vessels for this one?
Exactly. Now, the design can be a VY or a step cut.
And it's based on just one digital vessel.
Right. Got to keep that other one safe and sound for sensation.
And you dissect it all the way to the palm bifurcation.
Yeah, then you can advance it up to 2 centimeters, even with some finger flexion.
Pretty cool. Thenar and hypothenar flaps. Those are for when you need more coverage.
You got it. Think exposed bone or tendon situations where a graft just won't cut it.
What are the downsides?
Well, not ideal for older patients or those with arthritis.
Or anyone who won't stay still, basically.
Pretty much. And
Yeah.
remember, this is a 2-stage procedure.
So you raise it, then divide it after a couple weeks?
Yep. 10 to 14 days usually. And be mindful of stiffness after all that immobilization.
Good point. Okay, cross finger flap. Let's hear about that one.
This one's for fingertip or volar defects again when there's exposed bone or tendon.
Same contraindications as the thenar and hypothenar flaps.
Exactly. So you design this flap on the back of the middle phalanx on the neighboring finger.
Based on the closest border, right?
Yep. You take full thickness skin but leave the peritoneum on the donor finger.
And you graft the donor site.
Of course. Now, after a week or two, you divide the pedicle.
But you can end up with problems like an insensate flap or cold intolerance.
Yeah, and don't forget stiffness in both fingers.
True, true. All right, reverse cross finger flap. When do you use that?
This one's for those dorsal defects that aren't good for a regular graft.
Same contraindications.
Yep, basically the same idea, but instead of full thickness skin, you just take the dermis and fat.
So you de-epithelialize it.
Exactly. Leave the peritoneum and then graft both the flap and the donor site.
Interesting. Now on to thumb reconstruction, starting with the Moberg volar advancement flap.
This one's all about those volar distal thumb defects, less than 1.5 centimeters usually.
And you got to preserve sensation there.
Absolutely. Now, the big no-no is injury to the princeps pollicis artery.
Because that supplies the dorsum of the thumb.
Right, and this flap relies on those volar digital arteries.
Okay, talk me through the technique.
So you raise a rectangular flap, including both neurovascular bundles.
Right over the flexor sheath.
Exactly. Then you advance it distally and flex that IP joint to get good coverage.
And for bigger defects, you can divide the skin at the MP crease.
Yeah, and graft that proximal defect.
This flap's pretty unique to the thumb because of that dual blood supply.
You got it. And keep in mind, you might see a temporary IP flexion contracture, but it usually resolves.
Good to know. Oh, and taking some of the thenar eminence can give you more length.
Clever trick. Now let's talk about the first dorsal metacarpal artery flap. This one's a workhorse.
For real, it can cover so many thumb defects.
Tip dorsum volar, you name it, degloving injuries, first web space contractures.
The list goes on. So tell me about this artery.
The first dorsal metacarpal artery, it comes off the radial artery and runs along the dorsum of the second metacarpal.
And it's got vena combatantes and those sensory branches from the radial nerve.
Yep, good for sensation. Now, you can base this flap proximally or distally.
So the proximal one's more common.
Right, usually on the back of the index proximal phalanx.
And you dissect the pedicle all the way to the bifurcation.
You got it. Then you can snag those radial nerve branches for sensation and graft the donor site.
Nice and efficient.
Okay.
Neurovascular island flap, also known as the littler flap,
This one's your go-to when you need that innervated coverage on the thumb tip.
for that all-important tactile pinch.
Exactly. Now, this one's got some specific contraindications.
Yeah, mate.
If either the long finger digital artery or the ring finger ulnar digital artery is out, you can't do it.
Because you need to ligate the radial digital to the ring finger.
Exactly. You got to make sure those other vessels are good.
So how do you do this flap?
You take it from the ulnar side of the long finger, dissect it out the neurovascular bundle all the way to the palm.
And ligate that radial digital to the ring.
Right. Then you tunnel it over to the thumb and voila.
And graft the donor site.
Of course. Now, this flap is awesome because it gives you sensation, and the donor site isn't super critical.
Makes sense. All right, let's talk hand reconstruction. Starting with that distally based dorsal hand flap, the quaba.
The quaba, this one's for small dorsal defects, less than 2 centimeters usually.
And for web spaces and dorsal proximal phalanx defects, too.
Right. Now, this flap relies on those recurrent cutaneous branches from the dorsal metacarpal arteries.
Which are where?
About 5 to 10 millimeters proximal to the MP joints. And remember, they get smaller as you go from radial to ulnar.
Got it. So how do you actually raise it?
You design it distally and then rotate it into the defect like a propeller.
Sounds fancy. And you can close the donor site primarily if it's small enough?
Up to 2.5 centimeters or so. Otherwise, you got to graft it.
Okay, now for the kite flap. What's that all about?
Think distal dorsal hand and first web space.
And it's related to that first dorsal metacarpal artery flap somehow.
Exactly. It's basically a variation. You design it as a proximally based transposition flap using that same artery.
So it's like a super specialized first dorsal metacarpal flap.
Pretty much. And the cool thing is you can often close the donor site primarily because of that rhomboid shape.
Awesome. So it's perfect for first web deepening or covering the base of the thumb.
You got it. Now let's move on to those big guns, the forearm flaps, starting with the radial forearm free flap.
This one's like the Swiss Army knife of hand reconstruction.
It really is. You can use it for pretty much any defect, large or small, volar or dorsal.
So versatile. But there are definitely times you wouldn't use it.
Oh, absolutely. Like if the Allen's test is abnormal,
Meaning?
the ulnar artery isn't providing enough backup flow to the hand. And remember, you're sacrificing the radial with this flap.
Right, so you could end up with a compromised hand.
And of course, if the radial artery itself is injured, that's a no-go.
Plus, some people just don't like the donor site scar.
Yeah, it can be a bit unsightly. Now, this flap comes in a lot of flavors.
Like what?
You can do it pedicled or free skin and fascia only. Or with sensory nerves?
You can even throw in some bone or tendons.
Yep. Piece of the radius, palmaris, longus, FCR, you name it.
Wow. So walk me through the anatomy.
Okay, so the radial artery and its vena comitante is the running between the FCR and brachioradialis.
And you got to watch out for those radial and median nerve fibers.
For sure. Now, the vena comitantes can be tiny, so sometimes you need to bring in the cephalic vein.
Especially for a big free flap.
Absolutely. Now, pre-op, you got to do that. Allen's test, make sure the ulnar artery is up to the task.
And using a pulse ox on the thumb can give you a nice objective measure.
Definitely. And it's helpful to map out the cephalic vein and radial artery with a Doppler beforehand.
Good planning.
Ah.
Then in the OR, you'll use a tourniquet and an unmeshed graft for the donor site. And post-op a wrist splint helps with immobilization.
Yep. Now, if you're worried about blood flow to the hand, you might need to reconstruct the radial artery.
Using a piece of the cephalic vein.
Exactly. And a good trick for finding the radial artery is to palpate it at the wrist and draw a line up to the antecubital fossa.
Handy tip. All right, what about the reverse radial artery forearm flap? How's that different?
So this one's all about retrograde flow in the radial artery.
Good name.
The blood's flowing backwards from the ulnar and anterior interosseous arteries distally.
So you can base the flap distally and bring it up to the elbow or even the forearm?
Exactly. Now, you can design a pretty big skin paddle on the volar forearm.
But you'll want to use a template to make sure it reaches.
Absolutely. And a Doppler comes in handy for finding those perforators.
Which are usually...
More common distally and proximally, not so much in the mid-forearm.
And your pivot point is around the radial styloid.
Right. Now, you can elevate this flap subfascially or superfascially.
So subfascially, you take the fascia with the skin.
Yep, helps protect the pedicle. And superfascially, you go above the fascia, but incise it over the tendons to protect the artery.
Makes sense.
Mm.
And of course, you got to save those sensory nerves.
Always. Now, the donor site's usually too big for primary closure, so you'll need a graft.
But a full thickness graft can look nicer if you can partially close it.
Yep. If it's less than 5 or 6 centimeters wide, you might be able to get away with that.
All right, posterior interosseous flap. This one's a bit less common.
It is, but it's got its uses. Think proximal dorsal hand defects like first web space injuries or exposed MP joints.
So when other flaps aren't an option?
Exactly. Now, the nice thing about this flap is you don't sacrifice a major artery.
That's a big plus. What are the downsides?
Well, you got to watch out for thrombosis in the posterior interosseous artery, especially after wrist or forearm trauma.
And if you're not sure about the blood supply, it's a no-go.
Right. And there's always the risk of hitting the posterior interosseous nerve during the dissection.
So how do you raise this flap?
Okay, so first you find the posterior interosseous artery. It's running between the ECU and EDM tendons.
And it comes off the common interosseous artery deep to the enconeus.
Yep. About 5 to 6 centimeters distal to the lateral epicondyle. Now, your skin paddle should be less than 6 or 7 centimeters wide.
To make closure easier.
Exactly. Now, you'll pivot the flap around 2 centimeters proximal to the ulnar styloid.
And release it all the way up to the DRUJ.
Right. And when you're incising the fascia, stay about 5 millimeters radial to that EDM septum.
Got it. And be careful not to damage those perforators.
Of course. And one more thing, there's a higher chance of flap loss if you try to cover defects further down towards the PIP joint.
Good to know. Okay, reverse ulnar artery forearm flap. This one sounds risky.
It can be. We mostly use it for elbow defects.
What makes it so risky?
Well, the ulnar artery is often the main supply to the hands, so taking it out is a gamble.
And you could injure the ulnar nerve, too.
It's right there next to the artery. So you got to be super careful dissecting.
Any other tips for this one?
Just remember the ulnar nerve is deep to the artery, and those vessels are running between the FCU and FDS muscles.
Okay, let's talk about elbow coverage. What do you think about when you see a small elbow defect?
First things first, you got to really assess the defect size depth, what structures are exposed.
So basically know what you're dealing with before you choose a flap.
Exactly. Now, for small anterior defects, you've got options like the FCU flap.
Tell me more.
So the FCU muscle itself, it's about 5 by 20 centimeters, so you get a good chunk of tissue.
And you can use it with or without skin.
Yep. Myocutaneous or muscle only with a graft, and it often looks better than the radial forearm flap donor site.
Plus, it's good for older folks who have thin skin.
Right. But the downside is you lose a major wrist flexor and ulnar deviator.
Not ideal for someone who needs a strong grip.
And it's tough to use it posteriorly, and you gotta watch out for the ulnar nerve.
So where's the blood supply for this flap?
The posterior ulnar recurrent artery usually branches near the radial bicipital tuberosity.
And it enters the muscle about 6 centimeters distal to the medial epicondyle.
Right. Now, if you're taking skin, keep the paddle under 6 by 10 centimeters.
And then sometimes grafting right onto the muscle gives you a better contour.
Yep. Now, another option for small elbow defects is the brachioradialis flap.
What are the pros and cons there?
Well, it's got minimal donor site morbidity since it's not a primary elbow flexor.
And you could do it with or without skin again.
But that skin paddle can leave a nasty scar if it's big.
And you don't want to sacrifice the brachioradialis if the other elbow flexors are weak.
Right. The blood supply for this one comes from a branch of the radial recurrent artery.
And the pedicle's pretty small, only about 3 centimeters long and 1 millimeter wide.
Yep. You'll find that branch near the origin of the radial recurrent. Now, when you're harvesting the flap, be sure to save those sensory nerves.
And you can include some tendon to help with inset.
Good idea. It holds sutures better than muscle anyway. Now, for posterior elbow defects, you might consider the reverse lateral arm flap.
What are the red flags for this one?
Avoid it in overweight patients. The flap gets too bulky, and anyone with epicondylitis or inflammation around the elbow.
Makes sense. So what's good about it?
Well, the donor site is right there in the same area.
Convenient, but the arc of rotation can be limiting.
Yeah, that's the downside. Now, this flap is supplied by the radial recurrent artery.
And it helps to include the skin over the lateral epicondyle.
Definitely. It's got a good blood supply there, and you'll probably need a graft for the donor site.
And it's always a good idea to use a template to check that arc of rotation.
Can't stress that enough.
Huh?
All right, let's move on to those distant flaps, starting with the pedicled groin flap.
This one's not as popular as it used to be.
It's true, but it still has its place, like when you need a lot of coverage, and there's nothing better locally.
So what are the pros and cons?
Well, the donor scar can be pretty hidden down in the bikini line.
That's a plus. But the positioning can be awkward.
Yeah, you gotta have the hand attached to the groin for a couple of weeks.
Not ideal. So what about the anatomy?
This flap is based on the superficial circumflex iliac artery.
Which comes off the femoral artery?
Yep, about 1 to 2 centimeters below the inguinal ligament.
Got it. Now, most of these pedicle distant flaps can also be used as free flaps.
You just detach the vessels and hook them up somewhere else.
Cool. Okay, let's talk free tissue transfer. Starting with the lateral arm flap, when would you use this one on the hand?
Good for both volar and dorsal defects when you need a decent amount of tissue.
And the contraindication.
Any elbow trauma or surgery on that arm, you don't want to mess with the blood supply.
Makes sense.
Good.
So what are the pros and cons?
Well, you can take bone with this flap if you need it.
And the skin paddle can be pretty big.
Up to 8 by 15 centimeters, plus the donor site's usually out of the way of the hand injury.
But it can be hypersensitive.
Yeah, and some people have elbow pain or forearm numbness after,
And it can be a bit bulky.
depending on how much fat you take. Now, the blood supply comes from the posterior radial collateral artery.
Which hangs out with the radial nerve.
Yep, so be careful there. Now, you want to center the flap over the lateral intermuscular septum.
And a Doppler is your friend for mapping out those vessels.
Absolutely. Now, let's talk about those other free flap options.
There are a lot.
There are, but we can run through them. So first up, the anterolateral thigh, or ALT flap.
This was popular.
It is. You get tons of pliable tissue, the donor site heals well, and it's based on the lateral femoral circumflex vessels.
Nice. Then there's the omental flap,
This one's got crazy good vascularity, and you can get a ton of coverage.
but you usually need a skin graft, and it involves going into the abdomen.
True. Then we've got the gracilis muscle flap.
What's special about that one?
It's got minimal donor site morbidity and a short pedicle.
So it's good for long defects?
Yep, or for limb salvage or even as a functional muscle transfer.
Because it's got the obturator nerve.
Exactly. Now the temporoparietal fascia flap, that one's super thin and well vascularized.
And you can usually close the donor site primarily.
Yep, it's based on the superficial temporal artery. Then there's the dorsalis pedis flap.
You could take extensor tendon with that one.
You can, but watch out for healing problems on the foot.
Good point. Now for a big muscle, the serratus anterior.
Supplied by the thoracodorsal and lateral thoracic arteries. You can even split this one up to give individual fingers some movement.
That's wild. Okay, and for really big defects, the latissimus dorsi.
It's a beast based on the thoracodorsal artery, and if you want less bulk, you can skin graft it.
Smart. Lastly, the scapular and parascapular flaps.
These are cool because you can take some scapula bone with them,
And the donor site often closes primarily.
but they can be bulky depending on the patient.
So many options.
Yeah,
So before we wrap up, any key pearls of wisdom about soft tissue coverage in the hand?
absolutely. Remember the fundamentals. First, you got to debride any dead tissue, stabilize fractures, and make sure there's good blood flow.
So get everything prepped before you even think about flaps.
Exactly.
Yeah.
And don't forget about the patient.
Yeah.
You got to know their functional status, their job, what they expect.
So a good pre-op assessment is key.
Couldn't agree more.
Awesome. This has been a fantastic deep dive into soft tissue coverage for the hand.
My pleasure.
I feel much more confident about those board questions now, knowing all the options for grafts and flaps.
Good. I'm glad. And remember, it's not just about memorizing the names. You got to understand when to use each technique.
Right? Indications, contraindications, anatomy, it all matters.
Absolutely. And thinking about all these reconstructive possibilities, it really highlights how intricate plastic surgery is.
It is. It's amazing what we can do to help patients regain function and improve their quality of life.
Couldn't have said it better myself.